Okay, shall I proceed with my talk?
Yes, sir.
And am I audible?
Yes, sir. Loud and clear, sir.
Okay. I thank CAS for having invited me to give my experience on managing meniscus using biological option, which is the commonest one, which we use our own blood and try to improve the healing. The whole idea of doing this exercise was actually thought over because there are success rate that is questionable in a meniscal repair, and if you can add biology to improve your meniscus repair results, why not? So with that thought, this topic goes in this breakup, basically a small bit of anatomy. We classify the tears because anatomy and classification is very, very important. Whether to do repair or meniscectomy, we'll discuss a bit. Principles of repair, failure rate, and how to enhance your repair would be the flow of thoughts. As we know, we need to understand the basic anatomy, and it has become different since the time Robert Smigelski has classically defined how the meniscus is attached, what are the zones, and how it is attached at the roots, and where the proprioception comes from, how the load is taken place on the medial side, that is the medial meniscus, as well as the lateral meniscus. If we don't address the anatomy and identify how the meniscus is attached and functions, then the whole idea of trying to repair a meniscus in every patient would be found wanting. Here is a brief description of what happens when the knee is bent forwards in flexion as well as in extension. There is a bit of movement that happens in the medial meniscus as well as in the lateral meniscus, but you can see that the lateral meniscus is more mobile than the medial meniscus, as a result of which the catching of the meniscus in an knee injury scenario is more common on the lateral side in an acute scenario than on the medial meniscus. Having said that, the load bearing is around 80% in the lateral meniscus, as well as in the medial side it is only 64%. If we plan to knock off a meniscus and then say that the meniscus is supporting your knee without exercising and understanding what has to be done, then the whole idea of preserving and improving the biology of the knee will be questionable. While trying to heal a meniscus, we also need to understand how the vascularity of the meniscus is there. We all know that the red zone has got the maximum blood supply, but at birth it is only 50% vascularized. But as we grow old and gray, the vascularity of the meniscus tends to decrease. So do we need to repair the zones in the red-white and the white-white zones? And what happens if we do without improving the biology? Yes, the mechanical loading and the joint motions will be questionable in a meniscus which can't take the load, which is not vascularized. We all know the functions of the meniscus. Basically, it reduces the stresses around the joint surfaces. It improves proprioceptions, aids in nutrition of the cartilage of the femur and the tibia, as well as it provides rotatory stability, which is the current concept where we are addressing a lot of ACL injuries without looking at how the root of the meniscus in the posterior part influences the stability of the knee. What happens when we resect the meniscus, or we plan a resection of a meniscus instead of repairing? When we remove a meniscus, say for example 1/3 of it, that is the inner 1/3, there is a 10% reduction in the contact area and 65% increases in the stress. Similarly, when we do a medial meniscectomy without a thoughtful process, 40 to 50% of contact area increases between the femur and the tibia, and the contact stresses in that area increase by around 100%. But on the lateral side, you can see that there is 200 to 300% increase in the stress across the condyles. So it is more, criminal to do a lateral meniscectomy when we know that the contact stresses increases. So it is important to preserve the biology as long as possible, and we need to know when to do that. Conner classified, in long time ago based on, different types of meniscal tears. And in those days, they said that most of the tears are not repairable. But nowadays, because of the improvement in the fixation devices and the knowledge of the biology, most of the meniscus can be repaired. Even the complex meniscus, which Conner mentions that saying it is an irreparable tear, we can still repair that. Cooper also classified based on the zones in the middle third and the posterior third and the anterior third. So these zones of classification should be kept in mind because these areas differently react when the knee moves in motion, and the load transfer is different in these meniscal zones. So does this in particular possess the ability to heal given a proper environment, or the ability to heal and the potential to heal? Will this meniscus regain proper mechanical function after the healing has occurred? These questions should cross your mind while we are trying to repair a meniscus. The principles of repair are very simple. We need to do vertical mattress sutures. We have to stack the repair, and we should use improved technique or hybrid technique to improve the quality of the repair. We should be able to understand which are the meniscal tears that can be repaired. We should be able to understand what type of meniscus can be repaired and which are the ones we can try repairing. The meniscus which is reducible, which are stable, which are caught in the early part of the pathology in a younger patient, and of course when there is a concomitant ACL injuries, we need to repair this meniscus. We need to enhance the technique of repairing the meniscus by mechanical stimulation, marrow venting, fibrin clots, and a questionable value of whether the PRP influences the healing of a meniscus should also be thought about. And people should know that we have a commercial value to it, but does it really add value to the biology of healing of a meniscus should be thought about, read thoroughly, and practiced. These are the different techniques that I use in my practice. One is rasping, which is a very common thing that everybody can do. Marrow venting can be used using a microfracture awl. We can also do microfractures in the meniscus rim. And of course, the crux of the talk, that is how to use a fibrin clot to improve the meniscal healing, will also be discussed in the next slide. So allow me to play this slide for you, and you can listen how we do a fibrin clot meniscal repair.
Hi, I am Dr. Rajkumar Amaravathi, presenting to you augmentation of meniscus repair using fibrin clot. There are no conflict of interest with this presentation. A 32-year-old male presented to us after 3 weeks following a road traffic accident. He had pain and swelling in the right knee, and his clinical test revealed medial meniscus tear and ACL tear. Standard preoperative scores were low with a high pain score. On magnetic resonance imaging, in the sagittal image, we can see that posterior horn of the medial meniscus is shown, which is marked by the white arrow. In the coronal image, we can see posterior lateral tibia being contused, meniscus tear being marked again by the white arrow, and MCL strain is marked by the red star. In the sagittal image, we can see that ACL tear is marked with the black arrow. As we visualize the medial compartment, the probable meniscus tear is probed. To improve visualization, MCL pie crusting is done. Mark the needle that is coming into the joint. Once the pie crusting is adequate, the meniscus tear is visualized in the red-white zone. Rasp is used to freshen the edges of the meniscus. 40 to 50 ml of blood via venipuncture is collected in a glass beaker. It is stirred in a clockwise manner with sintered glass rod. The fibrin clot formed is then transferred onto the moist gauze and sutured with 2-0 Vicryl. Via a Gilchrist maneuver, posterior medial compartment is visualized. Spinal needle is then passed to assess the ramp lesion if any, and also to aid in passage of the guide suture, which is 20 PDS. Champion sling shot via the anteromedial portal is passed through the meniscus tear into the posterior medial compartment. The self-retrieving device secures the PDS sutures and brings it out from the anteromedial portal in this fashion. Fastfix 360 is now used to secure the meniscus tear. Please note, once the sutures are passed across the meniscus, they are kept loose order to aid in passage of the clot through the meniscus tear. The clot is then tied to the previous suture and is railroaded via a transparent cannula in this manner. The Wissinger rod will help to negotiate the clot into the meniscus tear. As the clot is seated into the meniscus, the sutures are gently pulled simultaneously and they are tightened. After making sure the clot is secure, the controlled tensioning of the meniscus sutures is done, and then they are cut to the appropriate length using the suture cutter. Additional fast fix sutures may now be used across the clot or across the meniscal tear to augment the meniscus healing. Thank you team for helping to make the video, and thank you for watching.
So we have published this technique in the arthroscopy journal. You can view this on the ISOCO's website as well as in the read through the arthroscopy technique, and I am sure this will add value to the already known techniques of repairing a meniscus. We also would like to try to tell you that any complex meniscal tear that you will see and come across in your practice should be viewed with caution, because not all complex meniscal tear will require a resection. And this is how we do. This is the complex meniscal tear of the medial side. You can see that the meniscus is torn in different areas. And when we see such a tear of the meniscus, the first thought that comes to mind is, okay, it is not salvageable. We have to do an ACL that is there, which is quick and easy, and this meniscus we can do away. But you note that the cartilage which is there on the tibia as well as on the femoral condyle is pristine. Should we, subject this virgin cartilage that is there on the femur and the tibia to wear and tear in early part of the patient's life, is a thought that everyone should think about before you resect anybody's tissue, because we have not given this meniscus to this gentleman or the lady. It is God that has given them, and it is important for us to preserve the biology in whatever way we can. So let me go through this presentation of a complex meniscal tear that we have done in our institution. This is the meniscus tear that you see in the image. And when we probe the meniscus, we are in for a losing chance of preserving this meniscus in a cartilage which is good on the femur and tibia. There is a root tear, there is a complex tear of the middle third of the meniscus, and the first thought that crosses any mind when we are seeing this tear is we have to resect. But if you think carefully and plan it well, you can preserve this root in such a fashion. And the first thing that we do is to take a shot at the posterior of the meniscus. It is like building blocks. So we first stabilize the posterior root with the device that is available from the Ceronics company. And we, suture that in such a fashion, and we stabilize that posterior horn first. After doing that, we'll see that there is a complex tear at the posterior third of the meniscus. We try to put racking stitches across the radial tear of the upper leaf of the meniscus in such a fashion. And we have to be very gentle when we do that, because it will cheese cut such a meniscus which is already fragile. Then we put a ripstop stitch across this meniscus tear, and we secure it. When the flap is very loose and it is moving freely in the joint, we can impale it with the spinal needle and do an outside in technique so that we can stabilize it temporarily as we do continuous suturing with the help of another device which is very nice from the Conmed company, wherein we can run continuous locking stitches, and dynamic fixation of this meniscus can be done with the controlled tensioning. So when we do such a thing, you can now see that the clear picture of the meniscus is coming to view. And mind you, till now we have not resected even a single bit of tissue from the patient's body. So that is the message that I want to give the youngsters who are watching this video. Spend some time. Yes, it will take your operating time when we try to do such a complex thing, but the result that comes out of doing such a gratifying thing for a patient who is young and wanting to have his knee in a way that he would want to have, that God has given him, would be very gratifying, not only for the surgeon but also for the patient's results. It will be good. Once we do this suturing in such a fashion, you can see that the meniscus is now stabilized well, and when we probe and find out this bit of meniscus that is there is stable now, and then I am sure if we give him a stable ACL and a knee which is very good in function and good rehab is done, this gentleman I am sure will go from being very bad to the day one to a good result in the coming days. And I am sure the results of the meniscal repair using the fibrin clot and preserving the meniscal biology for a longer period of time will aid you in giving good results to your patients with meniscal tear. Thank you very much for helping me to present this topic to you, and thank you all for listening to my talk. God bless you.